Okay, this is the MGB Mechanism of Action chapter, part 2, starting at slide 10. One of the concerns that leads to confusion is we have experts who are able to call on extensive knowledge of the Roux-en-Y gastric bypass, and they see no advantage and see no difference in the mini-gastric bypass. One famous Roux-en-Y surgeon said, other than one connection, it's the same thing. Why are you so lazy that you won't just do the additional anastomosis? So let's talk about the Roux-en-Y, especially in comparison to the MGB. In short, in summary, the Roux-en-Y, when compared to the MGB, the band, and the sleeve, the other most common bariatric procedures, has in every study the highest rate of complications. It's the most difficult to revise. It's not easily modified or tailored to patient factors. So a Roux-en-Y is a Roux-en-Y to a Roux-en-Y. One of the important points we'll come back to is we're going to talk about its mechanism of action. Although it has a component of malabsorption and duodenal exclusion, in particular, its primary effectiveness is based on obstructive restriction, that it causes a partial blockage to the eating of normal foods. And the process that this forces the patient into is attempts to eat normal foods leads to discomfort, nausea, and vomiting. So that over time, patients are forced via aversive conditioning into eating more liquid calories, and as this occurs, there is a failure of the operation with weight regain. Of course, the other tragic, worldwide recognized complication is the incidence of internal hernia, which has been widely stated, widely understood, that even with suture repair of the defects created, internal hernia is relatively common with the Roux-en-Y technique and leads to bowel obstruction and death in a higher percentage than we would accept. The MGB, on the other hand, is a relatively easier to perform operation. In all studies in which it's been compared, the operation is shorter, it takes less time, routinely it has lower blood loss. In all studies in which it's been compared, it has a lower risk of complications. It's more powerful in every study that has been compared to or equal to the band, the sleeve, and the Roux-en-Y. Uniquely and importantly, the MGB is more easily revised, and it's easily tailored to fit patient factors. So in cases where there is urgent or need for greater power, the MGB can be tailored to an operation with more power. Or in the case, for example, of a thinner patient, a less morbidly obese patient, a thin diabetic, for example, where the weight loss should be minimized, the operation can modify itself back towards the old initial idea for the operation, which was the antrectomy in Billroth II. Therein you get the change in diet and a decrease in the malabsorption and an improvement in the outcome. So it's very easy to modify the operation using that technique. So the MGB is unique in compared to the Roux-en-Y in that it's easily modified. It can be tailored to the patient. Less powerful in cases where the patient and the surgeon likes that advantage of increased safety, or more powerful in situations where the illness is more demanding. Maybe most importantly is the mechanism of action, which we'll talk about later in more detail, is it's non-obstructive. There is not a stricture, a ring, a band, a tight, narrow blockage in the small intestine, and the gastrojejunostomy is not obstructive. This leads to an inherent fatty food intolerance and an intolerance of liquid calories in the well-described post-gastrectomy syndrome. Plus, the worldwide 20-year literature shows that although internal hernia can and does occur, it seems to be an order of magnitude or two below the incidence of the Roux-en-Y gastric bypass. So, to restate, new paragraph, Roux-en-Y gastric bypass, highest rate of complications amongst the band, the sleeve, and the Roux-en-Y. Most difficult to reform and to revise. Not easily modified to tailor to patient factors. It causes obstructive restriction, which leads to pathologic eating, increasing liquid calories, sweets, and junk food, and resulting in failure with weight regain. Plus, it is the sine qua non, the highest incidence of internal hernia leading to small bowel obstruction, and all too frequently to death of the patient. The mini-gastric bypass, only in well-trained hands, results in lower risk of complications in published papers, in decades of follow-up, and in prospective randomized trials. In all cases, the MGB equals or exceeds the Roux-en-Y. It's more powerful, or at least equal to, every study of the band, the sleeve, and the Roux-en-Y. Its complexity as far as compared to the Roux-en-Y is significantly easier, and if you measure simply by operative time, it's relatively easily performed, equal to the sleeve, with a lower risk of tragic leak complications. It can be tailored to patient factors, and importantly, the patient can eat. Because of its non-obstructive restriction, fatty foods, junk foods are eaten less frequently, and it enforces something very much akin to the Mediterranean-type diet, and we'll talk about this later. Finally, it has a very low risk of internal hernia and small bowel obstruction, so that dreaded complication is much less common in these patients. If we look at the spectrum of different surgical procedures that treat obesity, primarily we see two mechanisms of action. Although there is a great deal of research now looking at the hormonal effects of the operations, still the primary mechanisms of action seem to be calorie restriction or malabsorption, and the calorie restriction is primarily through restriction of ability to eat a usual or comparable preoperative diet. But here there's quite a bit of difference between the type of restriction. For the vertical banded gastroplasty, the lap band, the sleeve, and the Roux-en-Y, the obstruction is what leads to the restriction. The obstruction, the band in the vertical banded gastroplasty and the band, the tight, narrow pouch and pylorus in the sleeve, and the very small pouch and small, tight, strictured gastrojejunectomy in the Roux-en-Y. In the BPD and duodenal switch, there is massive gut bypass, and this leads to high-grade malabsorption, and in many ways reminiscent of the weight loss and the complications that occurred with the early jejunal-ileal bypass. In reviewing these operations in comparison to the MGB, we can see that the vertical banded gastroplasty had ease of use but failed because of weight regain. The lap band has now all but been abandoned because of failure with weight regain. The sleeve has a growing incidence of failure, weight regain, failure of the treatment of diabetes over the long term, and significant new onset of GE reflux and the adoption or the publication of some of the first associated esophageal cancers following sleeve gastrectomy. The Roux-en-Y has the combination of the highest complexity, the most difficult to perform, the highest demand on surgical skill, the highest complication rate, the highest risk, weight regain, and the unique high risk of small bowel obstruction. The biliopancreatic diversion, duodenal switch, and other distal bypass operations have powerful weight loss, but these are associated with malnutrition, deficiencies, diarrhea, foul-smelling gas, and other severe and significant problems. So as we talked about, the majority of procedures that are performed in the world today are obstructive restrictive procedures. Okay? So the band, the sleeve, and the Roux-en-Y decrease weight primarily by obstructing the intake of food. The mechanism of action is a restriction on the intake of calories, primarily by an obstruction. And this is simple to understand. The lap band creates a narrowing at one and only one place. The sleeve creates a long tube with a high-grade obstruction throughout its course and a high-grade outlet obstruction with the pylorus, which has been denervated in many cases. And the weight loss is induced by this high-grade narrowing. This also includes the Roux-en-Y, which has the same small pouch and high-grade narrowing of the gastrojejunostomy. And this high-grade narrowing or stricture leads to obstruction in the eating of normal food. So, for example, normal healthy diet, and we can use as an example broccoli, a sandwich, an apple, and other bulky and tough fibrous foods often leads to partial obstruction of the outlet of the band or the sleeve of the Roux-en-Y, and vomiting, high pressure reflux above it. And over time, the patient learns that this terrible, negative, painful, unpleasant experience is not one that he or she wishes to face, and so they modify their diet. And so the operation itself induces a pathologic eating pattern. That is to say, they begin to recognize that Coca-Cola, sweets, soft calories, candy, ice cream, etc., potato chips, pretzels, junk food, are easily tolerated because they can be taken in small amounts, and the high calories and sweets and fats can satiate their desire to eat. Ultimately, all of these operations over time have relatively high incidences of weight regain. And this is the end of part 2, slide 15.